Well, and I think uh, from what I was seeing, looking at the chat so far, I think we've managed to go through pretty much all of the questions that had been typed in the chat. So I guess as we go along, if you have questions, I guess type your new questions. So first of all, thank you very much to all the speakers this morning, afternoon, respectively, for some really wonderful and illuminating talks. And just to kick things off, and just because it's a question, it's a non-COVID question, which are or a non-COVID thing, which is rare these days. Question for, I guess, Marie. Does the Ebola vaccine that you were looking at, does it have does it protect against severity, or rather, does it lower the severity in breakthrough infections?
Not sure to have the answer, but the data that we have been so collected so from 2014. So after the severe infection, the severe breakthrough, but I'm not sure. I don't really know how to answer this question. I don't want to say something wrong, actually.
Sure. No, I was just, and again, I mean, I guess everything very quickly gets back to COVID. I mean, I was wondering by analogy with COVID, where we know that, a very important protective effect of the vaccines is not just that they prevent infection, but that they prevent, they make infection less severe in those people who are vaccinated, but still do become infected. And you were talking about, using this sort of modeling potentially also for COVID. And I mean, we talk about waning of immunity for COVID vaccines. And I'm wondering if, the modeling that you've been doing, and again, this is sort of jumping one step ahead, because I guess this is jumping ahead to using it for COVID. If that can give you some sort of an insight into what is the waning of the vaccine against, protecting you against getting infected in the first place versus protecting you against, severe disease if you do get infected. And, I'm wondering, is that something that the modeling could in principle get at, or does it not quite work like that?
I think that's something we could include in the modeling, but not in the models that I don't think that it's possible in the models that I presented. It's a too simple model, or maybe if we transfer this information in terms of decade rate of long-lived antibody-secreting cell, for example, or something like this. But I think it can be possible in the extended models that we are currently working on, taking into account the memory B cells and things like this, because we can really see the waning immunity induced by the memory cells. So not in the models I presented, but I think it's possible.
Okay. That's let's see, another question, and this one I guess this one would be primarily for, or really for, Marie. You were talking about, I mean, you're using this K index for measuring the degree of application of non-pharmaceutical interventions. So does that, I guess it encompasses both reduction in contact rate just to people distancing and maybe staying home rather than going out, but also the reduction in the actual transmission probability if there is a contact from, I guess, primarily wearing masks. I mean, both of those things, you know, you can just, I guess, multiply together to get the rate of infections, or the rate of potentially transmitting, or the rate of, you know, potential transmission. Does and I'm sorry, I missed that if you were saying it when you were giving your talk. Are you having the transmission rate in your model change linearly with K, or is it a more complicated relationship?
I think changing the transmission rates are linearly with K, but maybe Jane can just confirm, because is it the case, Jane?
Yeah.
Okay.
It's just it's something that changes the infection rate across all of the age groups linearly. And so it's assuming that barrier gestures are adapted linearly across the population, irrespective of age.
Right, right. So I mean, from that perspective, I guess it would be equivalent whether you reduce the contact rate to half, or whether you leave the contact rate as it is and you reduce the transmission probability per contact by a half, by say higher mask compliance.
Yeah, it's also a way to, like, if your public health mitigation matrices, the contact matrices are too strict or too relaxed, then it allows you to scale the model so that you can capture.
Right. Yeah, I mean, that's an very interesting question, I think, because, you know, things, you know, stuff that I've tried to look at too, and you know, with myself and collaborators, trying to assess how do you, you know, first of all, where do you get information about you know, stringency of non-pharmaceutical interventions, you know, both from the perspective of what are the regulations, and, you know, more importantly, what is the actual compliance, and then how do you translate that into, you know, into the actual effect on transmission. I suppose ideally, if you have, I guess ideally what we would want is the compliance rate, or the rate at which people wear masks, and we have some notion of the efficacy of masks, or the, you know, the reduction in transmission due to a person wearing a mask. But I guess generally we're sort of stuck with abstracting things a bit.
If I could jump in, Ed, I think so we have in our transmission models, we have physical distancing and masks reducing susceptibility if you're susceptible, or infectiousness if you're infectious. And we have compliance in our age structured models being age specific. But the problem I have is with efficacy. I really think, of course, we know what the efficacy of an N95 mask is, but if it's properly worn by healthcare workers who are trained to do that. But if you walk around, you see people wearing all manner of masks and wearing them improperly, and sometimes taking them off to speak. And, you know, I think the efficacy of masks, you know, I'm all in favor of masks, but I just think it's really an unknowable parameter in transmission models. Anyway.
Yeah, no, that's a really good point. And I guess, I mean, in some cases, you know, if one does get to this sort of simplification, or, you know, some degree of abstraction, where you say reduction in transmission is the product of, you know, reduction in contacts times probability of transmission per contact. And I guess if you then have data on mobility, on you know, proxies of contacts, such as we have from Google data, and there are other sources for that too, then you can try to disentangle which part is due to reduction in contacts and which is due to reduction in the actual, you know, transmission probability when there is a contact. But no, it's certainly it's a very good point that, you know, a mask is not a mask. Let's see. I guess getting back to oh, actually, yes, we have a question in the chat. Wonderful, from Jacques. who asks, can the variability of, sorry, actually, what I should have said first is, would anyone else, aside from me, like to comment on the comment just now? Okay, then we'll jump to Jacques' question, and who asks, can the variability of waning of immunity as a function of age be extrapolated to children and inform the vaccination needs for the under 12 population? As we're hopefully, we're starting to do or will be starting to do in the US, right, basically now and hopefully soon in Canada. And so any thoughts on, and I guess there's a second part to the question, but first of all, for the first part of the question, any thoughts from any of the speakers?
I think the information about waning is pretty limited in all groups except persons with immunocompromising conditions, elderly people, and things of that sort. But it may well be that we could extrapolate at some point to younger people. But I don't really think the data are very compelling yet, except among the groups that I mentioned.
Mm-hmm.
I can say that there's been a lot of work trying to understand how a child's immune system is different to an adult's immune system for COVID, and there still are a lot of unknowns. And so I'm not sure how age-related waning can be extrapolated from what we know about adults, except that we also do know that children have a milder infection. And so in different proportions or different probabilities of what they get. So I don't know. There could be some look at mild infections in adults and then have some average, but it's hard to know. And also we have to think about susceptibility for children too and how it differs in transmissibility.
And the second part of Jacques' question is to follow up on the remark by John, is it hopeless to isolate the effectiveness of the different NPIs? For example, the curfew that was put into place in Quebec. I guess can you pull these apart, or is that a hopeless proposition?
So I'm not sure that it's doable in the United States by virtue of the heterogeneity in terms of what was done and when it was done, and in terms of imposition of relaxation. But we've done some work in smaller, more homogeneous settings, in particular in Argentina and Jamaica, where we have disentangled some of the interventions that were put into place and made some recommendations about when and if they should be relaxed. So I think it probably depends on the setting. Maybe I can just leave it at that and ask others if they have experience trying that.
I know that a group at the University of Bordeaux has tried to assess the efficacy of public health mitigation strategies during different periods or look at the efficacy of those. And I'm wondering if Carole or Marie might be able to provide more information.
Yes, they tried to access the efficacy on, for example, curfew at different hours, because in France we had curfew at 6 p.m. or 8 p.m. and they tried to estimate the efficacy of these measures, or school closing school also, on transmissions. And first they have estimated, well, I don't know everything of the method, but I think I know that they have estimated transmission rates with the method which is called Kalman filter. And then when they have estimated this transmission rate, they used linear regression to estimate the effect of each NPI taken at different times. So they have expressed the NPI like on-off binary variables, and they have estimated the effect on transmission thanks to linear regression. Well, it's not a perfect methodology, but it helps to estimate, have an idea of each NPI efficacy. If you're interested in, I can share the article. It's Annabelle Collin, the author.
And Jane, you had also typed a question to John. Can you elaborate on your work related to ascertainment by age, which I'm maybe can also be kind of combined with a question similar to the one that I asked John before also the seroprevalence work by Rahul. And I guess the question is in this, well, I guess the second part of the question is, in the seroprevalence work, is it possible to get, I mean, I know that there's a significant sparseness of things and also temporal resolution, as you were saying, but does one get kind of an idea of how the under ascertainment has changed over time? I mean, we know it was very severe in the beginning, but hopefully by now, you know, we're probably catching a much larger proportion of the cases.
So there's a nice table in the article by Jefferson Jones that's in JAMA, has been published in JAMA recently, where he shows a time course of that. And as you said, Ed, it was higher initially, or his estimate was higher initially, about a little over three cases occurring per report, but down to closer to two more recently. So there is some evidence for that in his article.
And I'm wondering, Rahul, from the seroprevalence side, do you see something similar, or is it too difficult to really resolve this temporally from seroprevalence?
So I would say, John, I think the study you're referring to is one of the seroprevalence studies as well, yes? And so, if I'm not mistaken, and so I think in certain places where we have seroprevalence data of high resolution, we can certainly draw some of these conclusions, and the US, Canada, UK, some other countries certainly fall into this bucket where, you know, you can look at the seroprevalence difference between two periods of time and kind of calculate the ascertainment for that period of time. It does get quite a bit more tricky on the global scale because of the sparsity of data globally. And so to answer the other part of the question in the chat, I mean, my impression looking at Canadian modeling is that geographical covariates like access to healthcare and so on probably doesn't help so much in the Canadian context, because the density of seroprevalence data is sufficient that those sorts of data aren't really necessary to fill in the gaps. That said, in the global context, the covariates, which can inform the likely extent of testing availability and the likely extent of ascertainment, seem crucial to estimate the true extent of past infection and hence protection.
And thank you very much for you're already on to the next question. That's great. And I'll just repeat again the next question, which is the last one that I see in the chat here, which was, how important are geographical covariates such as access to healthcare in estimating, or how important could they be in estimating true immunization level in population having seroprevalence and cumulative notification infection data, and specifically for the US and for Canada? Wondered if any of the other panelists have thoughts on that.
Well, I guess I can add that I mean we can detect immunization rates in the blood donors survey, and that can certainly be stratified by state and by urban area and some others sociological covariates. I have not done it personally, and I'm not aware of anyone having done it, but I think it probably can be done, and it's an interesting question, and I'll pass it on to my colleagues in the seroprevalence team.
Yeah, and maybe perhaps if I can clarify my comment earlier, it was perhaps that looking at, covariates like access to healthcare on a province by province basis or on a country, but we haven't found too helpful in the Canadian context. On a country by country basis feels really important in the global context. But to echo John's point that there seems to be considerable heterogeneity in seroprevalence and the extent of infection by these sorts of socio-demographic or sociological factors, and that looking at those is certainly important to understand the heterogeneity and how that immunity or how that protection is distributed within the population.
Slightly different question or slightly different direction. This is really principally directly relevant to the transmission modeling work. So I guess principally Carole and John. So we see a lot, I guess a kind of a standby of getting transmission data is the work by Prem et al. And I'm just wondering, and I'm asking this for selfish reasons partially, if I can, what are your thoughts on the the validity and the applicability of the Prem data, in your experience? Does it does it seem like a good characterization the way they extrapolated contact rates for other countries, and what are some of the limitations that you've possibly seen? Any thoughts or feelings on that?
Well, I could address that a little bit. I've thought some about contact studies over the years. We find them. We found them useful in China, although there is a contact study in China, in southern China. It doesn't have the age resolution that we needed for our transmission modeling, and so we ended up looking at that, and also looking at the basic polymod study from Europe that it's based on. We ended up using polymod, but that was just because we started work on this before the Prem work came out. And then we were proposing to use the Prem studies in the US, even though there have been also studies of contacts in the US. And they're pretty heterogeneous or inconsistent in some respects. So they use different methodology, and that may account for some of the differences. But I think these, I think these studies are wonderful, and they're a tribute to John Edmonds' pioneering work on this. But I think that the source of this kind of information is about to change. I mean, we all carry around these devices that have GPS capabilities, and I think we're about to be well. In fact, there are data of this sort right now that some people are making use of, and so I think contact studies are about to become a lot more useful. These GPS-based ones, anyway, and so long as they can be coupled with proximity detectors, and and there's some kinks to be worked out, but I think this is crucial information for transmission modeling personally, and I'm looking forward to some of these technological innovations.
I think that's a really important point. I mean, we have this wonderful, well, first and foremost from Google, but I mean, there are certainly limitations in that, but we have other sources of information. Also, you know, there are other companies, you know, that, for instance, used to kind of specialize in business intelligence, you know, visitation to stores and stuff, and then realized that you could repurpose this for epidemiological things. One other, and I actually came across an article in, I don't know if it was the New York Times or somewhere else, that was saying that, you know, these exposure notification apps that, you know, many of us, maybe most of us probably have on our phones since early on in COVID, which I think we can generally agree didn't really do a whole lot, because, I mean, notifications are just so rare. But the article was saying there really is a missed opportunity there, because you can simply calculate the rate of contacts in general in a region and send that, you know, store that, you know, in real time or semi-real time, so that by, you know, you get this geographically stratified, really, you know, contact rate or proxy for contact rate, if you take into account that not everyone has one, which I thought was a really interesting idea. So in a sense, you could get kind of an early warning system, even, where it would tell you if there was an especially high, you know, rate of contacts in one particular place, say there was a concert or who knows what, protest. So I guess to try and, oh, sorry, go ahead.
No, I totally agree with you. I think the problem is you have to buy into these things, and and I think that's unfortunate. Nobody, I mean, Google makes good use of this information for navigation purposes, and we all use that. But you know, they didn't ask us if they could make use of our location data for that purpose. And I think it was really it's the privacy concerns, though, that are limiting buy-in to these devices. But and these apps, I guess, is the right word. But I think they're capable of generating extremely valuable information, not just for research, for practical purposes.
Right.
And
I see we're at 12:30, so I should quickly ask any final, very open-endedly, any final thoughts or closing thoughts from any of the panelists, maybe things that we didn't quite get to in the discussion.
Nope. So I'd just like to thank Ed and John, Marie, Carole, and Rahul for their participation in their talks and their panel discussions for this morning's sessions. And just remind everybody that that we now have a half an hour break, and we'll see everyone back in 30 minutes for the next session. Thanks, everybody.
Thank you very much.